A very good afternoon to everyone. Thank you for joining in. My name is Smriti Lohiya and I'm from Health Parliament, today's co-host, and I lead Public Task Force for Accountable Healthcare. So this webinar is conducted by Public Task Force for Accountable Healthcare. So this initiative basically believes healthcare should not be supplier driven, rather demand driven, and based on care seekers' needs. It intends to make healthcare more accessible, accountable, affordable, and outcome driven. Public Task Force is the voice of people who are never heard. So today with us we have Dr. Sanjiv Kumar. So Dr. Sanjiv had such an aspirational journey. What we youngsters dream for, he has lived it. From getting into AIMS to being Executive Director at the National Health Systems Resource Center, NHSRC, Government of India. Dr. Sanjiv currently chairs the Scientific Advisory Committee of the National Institute of Cancer Prevention and Research, Indian Council of Medical Research, ICMR. He has 46 years of experience across 30 countries in the domain of healthcare. The list is endless, but I would like to mention one thing which I really got fascinated about. Dr. Sanjiv has worked for UNICEF for 22 years in India, Iraq, Kenya, Uganda, Somalia, and Bangladesh. He has also served as regional advisor for 22 countries in Central Asia, Central and Eastern Europe, and Baltic states. So today we are going to learn more about Dr. Sanjiv's experience in the healthcare domain and understand different aspects of healthcare from his standpoint of view and his experience. So it's an honor to have you with us, sir. Dr. Sanjiv?
Yes.
Are you audible?
Yeah, I can hear you.
Okay, over to Kritish.
So, hi everyone, I am Kritish. I from Health Parliament. Today, I welcome Sir on behalf of Health Parliament. I lead Public Task Force. So, moving forward, as we know, Sir, you are from India's premium institute, AIMS, All Indian Institutes of Medical Science. What has been your experience with patients whom you treated at AIMS?
Thanks, Smriti, and thanks, Kritish. And thanks to Rajan for putting this together. I was brought up in a small town, Hisar in Haryana. And coming from that town to AIMS, I had seen AIMS because my grandparents used to live in Green Park, and we often used to go to AIMS because we had never seen lift in our life in that town. So there was a lift in the hospital, and we used to go up and down in that lift. So it was like coming to a different world. And one thing which I carried from AIMS is whatever you do, you always aim for the best. Getting to AIMS, it was a dream for a person in pre-medical to get into AIMS. And in AIMS, the culture is the same. You know, you always, whatever you do, you put your best. And the faculty of AIMS was so dedicated. You know, they were the best in the field, not only in India. Some of them were brought from abroad by Pandit Jawaharlal Nehru personally to run that institution. They were so committed to teaching and committed to patient care. Many of them didn't have a car. They would come on bicycle. But when you read about what they have contributed to medical sciences, they probably didn't have any parallel. Patients care. Many of the patients landed up in AIMS because they had heard about AIMS. And some of them could have been treated wherever they came from. You know, I also saw common cases of fever, diarrhea, cough and cold, but they heard about AIMS and they came there. So there should be a system of providing primary and secondary level care closest to their home so that they don't land up in a place like AIMS and get mingled with the crowd, wait for their turn and waste their time and waste the time of of the doctor. The other thing I learned in AIMS is they post you in rural areas. In urban areas in Malvi Nagar, we were allotted families. So we interacted closely with the families, and some of them became lifelong friends. And some of the cases we treated at AIMS have been lessons for us for rest of our life. And that's uh, about AIMS upbringing, I would say, Kritish.
Okay. So, sir, when you worked in African countries like Kenya, Uganda, Somalia, and others, what was different from India? I mean, what were the health conditions? Were they worse? Were they better or similar to India at that time?
Every country is different, and for that matter, in India, every state is different. You have some of the states like Kerala and Goa who have indicators which are comparable to developed countries. And then you have states like Madhya Pradesh, Odisha, Assam, Rajasthan, where their indicators are close to some of the countries in sub-Saharan Africa. So similarly, each country is different from the other. So what I learned from some of these countries, I will talk about social aspect first, and then come to what from health point of view. When I worked in African countries, I worked in Somalia, Kenya, Uganda, and Malawi. Most of these countries have a common language called Swahili. There is a word in Swahili called Ubuntu. Ubuntu is, one of the scientists went from the West and he wanted to play games with children. So he kept some goodies on the other end of the field and asked the children to run. Whosoever grabs the goodies will have it to himself. These children got together, they held each other's hands and they were dancing, singing, and they went to the other end and all of them shared the goodies. That is the culture. In African countries, nobody sleeps hungry if your neighbor has food. I also visited one family where the mother had died of AIDS and the father had died of malaria. There were 3 children and the youngest children had polio. So we went to trace that child. The 3 children were staying in a separate hut. But the neighbors were making sure that somebody comes to give them breakfast, somebody comes to give them lunch, somebody comes to give them dinner. This paralyzed child had one leg which was paralyzed. So he was not able to walk to the hut which had the toilet. So the neighbors got together and they put 2 sticks, vertical sticks like this, and then a stick to connect the upper end. So this child didn't have to crawl. The child could hold the stick and walk to the washroom. So, the society is more well-knit. I thought in India we look after each other very well. But when I went to some of these countries, I realized we can do better to look after our neighbors. Health systems, when I went to Central Eastern Europe, these countries were former Soviet countries like Yugoslavia, etc., which broke up into smaller countries, and former Soviet countries also broke up into 15 countries. So when I started, there were 28 countries, and in UNICEF, they say you graduate. The countries which are doing well in health and they have good resources, they graduate out of UNICEF program, but they become donor countries for UNICEF. So when I left, there were 22 countries. What struck me was when you look at doctor-patient ratio, when you look at population bed ratio, these ratios were better than European countries, better than US and Canada. But their health indicators plummeted down when they moved from the central command economy to market economy. Because what happens when you're in market economy, like in India, you have to justify, I need, say, 100,000 crore rupees for taking care of health. The finance minister and the Ministry of Expenditure will ask you, where will you spend this money? So when they were socialist country, they had no questions asked. Whatever money education wanted, health wanted was given to them. But when they moved to market economy, they had to justify. And all of you know that it's very difficult for you to justify that if you give me 100,000 crore rupees, I will reduce infant mortality rate from say 40 to to 10. Very difficult because there are so many compounding variables which you need to address, not just the money you put in the health system. So that's another eye opener for me, that you need to go beyond health system when you want to address the health needs of the population. So, and then I started looking at social determinants of health. What is the economic setup of a country? How does that economy impact on health? Earlier, as a medical graduate and postgraduate from an apex institution in India, I thought I knew everything. But there's a lot of things, and that made me interested into doing MBA. So at the age of 53, I enrolled myself into MBA so that I understand more about management. I understand more about things beyond health, which help us in improving health. Hospitals, primary healthcare institutions, there were plenty. And from the African countries, what I learned is we are too dependent on doctors in India. In both African countries and other developing countries, and in the developed country, you have somebody below a doctor. They call in the West they are called physician assistants, or nurses who become doctors are called nurse practitioners. In the African countries, they are called clinical officers. They are trained for 3 years after class 12, and they start treating patients. So after spending couple of years in Kenya, for example, I realized that this gentleman is not a full-fledged doctor, he's a clinical officer, but he was able to treat almost all the common cases. In India, when you start community health officers in health and wellness, IMA is up in arms against, you are giving, but you don't really need doctors at that level. You need somebody who can manage common ailments, and if required, they can refer these cases to the higher level. But we are so stuck with MBBS doctors, and we used to have LSMF. I don't, your generation hasn't seen it. We used to have licentiates. And I was treated by 2 licentiates when I was a child. In one neighborhood, there was one, and when we moved to another neighborhood, there was another one. So you don't really need these doctors. Now, even for family medicine, they say you have to be specialized. After MBBS, you do another 3 years, and then you become family physician. So we are, I think, becoming too doctor-centric in healthcare. We need to be more flexible and look at a cadre in between doctor and the community level worker. Thank you.
So, sir, according to you, what India can learn from the healthcare system, like not just African countries and various other countries which you have visited? Like, yeah.
Yeah, Kritish, you can learn from, I often say that you can learn from anyone, provided you are open to learning.
Okay.
Often in India, we come across bureaucrats, and I include the doctors who are managing health programs in India. They have a feeling we are India, we cannot learn from Africa. What can we learn from Bangladesh? These are poor countries. But no, you can learn from even these poor countries. For example, US can also learn from India what we are doing in India. How did we manage to reach vaccination of 97% population with at least 1 dose or 2 doses or booster doses? But you have to have that open mindset. And to give you example, what you can learn, I told you about community health officers. Below community health officers, like we have ASHA, they have community health workers. They have been there for a long time. And I remember once we brought a team from the Ministry of Health from Kenya to India to look at Mitanin. Mitanin is a precursor of accredited social health activist. Asha se pehle Mitanin naam hota tha unka. And that model has been scaled up in the whole country from Chhattisgarh. So that's one. I think community state. Similarly in Bangladesh, the community level activities are very strong, and the community level NGOs, small NGOs have been involved in supporting healthcare delivery. So that's one thing I thought we can learn from these countries. The second point, Kritish, I will say we can learn, healthcare is not doctor alone. When you talk to people in the government, or also people who are not really aware of how healthcare delivery is taking place. Healthcare delivery is a team effort. If you have a doctor at PHC, but you don't have a dispenser, you have a doctor, but you don't have a lab technician, you have doctor, but there are no medicine, no equipment. So it's a team effort. You need, all these paramedical workers along with the doctor, and also you need supplies. If you have the whole team and no supplies, how will they deliver healthcare services? That's the second message I will say. I can go on, but these are the two important lessons I thought we can learn from these countries.
Yeah. So, sir, we would like to know when you came from Africa and saw how health conditions there are, were you able to bring some changes in the system here in India?
Two, three things come to my mind. One is public health cadre. For example, in many countries, the public health department is separate from the hospital care department. In India, they are put together. In Kenya, for example, you have two ministries. They are often separated and brought together. One is the Ministry of Public Health, which has peripheral healthcare system, and then you have Ministry of Medical Care, which is hospitals alone. So these are separate people. So primary healthcare doesn't get that importance in India. And I have been advocating for establishing public health cadre in India. And if I remember correctly, 2014, I wrote an editorial in the Indian Journal of Community Medicine to advocate for public health management cadre. After Dr. Vinod Paul took over as advisor in Niti Aayog, he started pushing for it. And when I went to the first meeting, I was pleasantly surprised that my article was shared as a background material with the participants on how we can roll out public health cadre. And that public health cadre in April 2022, government has issued guidelines to all states in India to roll out that public health management cadre. I don't take the credit, but I was also one of the advocates for this, and I'm very happy things are moving. In India, we are very good in documents. But what is actually done in the field always remains a question mark. So hopefully this cadre will be rolled out, and I hope it will be effective. Second was national health policy. Having gone around 30 plus countries, I understood what all should be in the national health policy. Whichever country you look after, you look at what is the policy, what is included in that policy. So when we came back to India, and Rajendra Prasad Gupta was also a key player when we were drafting the health policy, which is now known as National Health Policy 2017. And we made a very comprehensive health policy. And even today, I feel very proud that whatever needs to be included in the national health policy of a country was included. What we were not able to do is healthcare as a human right, because government needs to commit to it. You put it in the policy, then you can make it justiciable. I can go to the court that I fell sick and I did not get care. But we are moving in that direction. Primary healthcare, the policy says that 2/3 of expenditure on health, of total healthcare in India, should be on primary healthcare. So that has been given. The third thing I would say, when you treat a patient, say for example, blood pressure, when you treat a patient with blood pressure at community level, at primary health center, what will you do? When you treat it at the next referral level, what will you do? And when you treat it at tertiary level care, what will you do? Earlier, they used to have one uniform way of treating in our textbook. Wherever you are, you treat it that way. So we developed 12 standard treatment protocol guidelines, which clearly stated that at primary healthcare level, this is how blood pressure will be treated. At referral level, this is what can be done. And when primary healthcare provider will refer the case. Similarly, second, but the case has to go back. You once you go to hospital to a specialist doctor, you don't stay in the hospital forever. You come back home, and that needs to be managed by a primary healthcare physician based on what has been. So these three things come to my mind, but there's a lot more we can learn, Kritish, in what we can do better in India based on what other countries are doing.
Yes, sir, surely. So, sir, given your experiences, what role can technology play to elevate problems in healthcare? It's very specific to India.
Yeah. There are, we talked about human resources for health. You keep providing human resources. You have enough doctors, enough healthcare workers, which are not enough. But even if you provide, second level is what kind of skills they have. I am a doctor. If somebody comes to me with an injury, I don't know how to treat an injury. I don't know how to give first aid to a broken neck person who falls down and breaks his neck. And if I don't give proper care, his spinal cord breaks, and nobody, even in a highest level hospital, AIMS type hospital, can correct it. So I need to be very clear what needs to be done at which level. Those skills are required. After the skills, the supplies. I am there in the hospital. I have the skill, but I don't have the supplies. And the fourth and most important part is, if you don't have trust in the health facility, which is happening in government health facility, over a period of time, more and more people are going to private hospital. They are not coming to government hospital, and government is trying to improve healthcare. If they don't have trust, they don't come to hospital. You have doctors, the whole healthcare team, you have supplies, you have skill, and nobody to visit to these facilities. How can you provide services? And the trust building, one is when I go to a hospital where the government, I'm treated with respect. They listen to me. Not only me, they also listen to my family members. When you fall sick, more than Kritish, your parents, your other family members get worried. They should be giving attention to them. Then only one person is allowed, no one else is allowed. The other family members feel, and they don't feel satisfied. Then I should be given treatment. I should be explained what is being given and why it is being given. That brings to the quality of care. After I have received treatment from the doctor, if I take a medicine and I come back home and take one pill, and in the evening I start feeling nausea and vomiting, whom do I call? There's nobody. I will have to wait for next day when the doctor comes to the OPD, again go to the crowded OPD. And when I go there, I find doctor is not there. So some follow-up quality of care. Second, scaling up. For example, I started as project officer immunization in 1988 in Rajasthan. We had coverage of 15 to 20% across districts. Those days there were 30 districts. Now I think they have more than 32. So 30 districts, but it ranged only, and we had to achieve 80% coverage. We did achieve 80% coverage, but then it again went down. But why 80%? Why not 100%? We also need to look at when are we going to reach the last beneficiary. And most of the time, this last beneficiary is the most deprived one, is poorest of the poor. He doesn't have resources to come to the hospital, to come for healthcare. So how do we scale up and reach the last beneficiary? Then look around. Who is doing a good job? For example, newborn care, Gadchiroli. You may have heard of Dr. Abhay Bang and Rani Bang in Gadchiroli. They run an NGO. About 30 years back, they developed a model. Newborn mortality was very high in India. and we were not making any dent till late 90s. They had developed a model, a community level health worker, what can he or she do to prevent newborn death. And they documented it. They were able to reduce newborn mortality, if I remember correctly, by around 70%. That model was very reluctantly taken up by the government, took a lot of advocacy because these semi-literate TBAs were giving injections. So we agreed that, okay, that those injections cannot be given by A&M, though they are giving all the vaccines. But okay, to move further, we agreed on that, and newborn care was scaled up. And I am very happy to say 20 years down the line, we have been able to make a lot of dent in reducing neonatal mortality. We need to showcase India. That's what I was doing in Nairobi and Central Eastern Europe. Many people from those countries were sent by us to go to Gadchiroli and look at newborn care model. You know, our country is doing important thing, and I am a proud Indian. I am a proud Indian. So what we are doing in India needs to be showcased to the rest of the world, which is happening now. So these are some of the things which come to my mind. What can be done in improving quality of care?
Yes.
Just wanted to give a little information. Digital Health Associates is launching an initiative, International Patients Union, on April 6th this year at a conference in India International Center, New Delhi. So this conference will focus on patients and will bring all the stakeholders in the healthcare under one roof.
Good to know that. And you will be organizing this?
The Digital Health Associates is organizing, yes, sir.
Okay, good. I like to be a party to that, at least listen to what goes on in those discussions.
Look forward to it, sir.
So, sir, moving forward, is health schemes like Pradhanmantri Jan Arogya Yojana enough to provide health assurance to people in every aspect?
There are two components of Pradhanmantri Jan Arogya Yojana. One component is strengthening primary health care, and that is being done through health and wellness center. And the second component is hospital care, up to a limit of 500,000 rupees, 5 lakh रुपए तक का उनको treatment free मिलता है. So we need to, these are very well planned activities, and as I told you, the taste of the pudding lies in implementation. So we need to evaluate how much, but fortunately we have some information available from, say, National Health Account. Recent National Health Accounts have shown that out-of-pocket expenditure in India has gone down. So it is making some difference, but I am still concerned what proportion of people who need care are actually coming and availing care. What are the bottlenecks? Those who reach hospital, do they really get care? And if they get care, what is the quality of care? Because government fixes rates, and at times private hospital rates are much higher than what rates government fixes. And they need to get the money in time. If they provide care to beneficiaries of Pradhanmantri Jan Arogya Yojana, they should get reimbursed very promptly. They have put in place a digital system of monitoring, but these are the aspects. And second is we need a comprehensive evaluation, or if not evaluation, of review. Has health and wellness center made any difference? Has this treatment in the hospital brought in more people who are deprived of health care? And then learn from that review or evaluation, whatever you want to call it, and continue to improve the system. So, but I'm very optimistic. The largest insurance, social insurance scheme in the country, very big initiative on health and wellness center. But as I said, we are putting in community health officers, but only in public system. And 60% of people in rural areas go to private care provider. They may be street corner registered medical practitioners or quacks or whatever, or one person clinics, individual owned clinics they call it. In urban area you have hospitals, etc. In urban area it is 70 to 80% people who go to private sector. So unless they integrate private sector into providing primary care and also providing hospital care and bring down the cost of medical care, it is escalating. By the day you are spending more and more on healthcare. So some of these aspects need to be looked into, but it is an excellent initiative, a bold initiative, I would say, the government has taken in providing healthcare.
Yes. So, sir, according to you, will India be able to achieve health for all in near future?
Yes, very important question, Kritish. Before I answer that question, I will say health and medical care are two different things. Unfortunately, healthcare means you have to keep the person healthy. Medical care is when the person is sick, you give them medical care. Either he recovers or he is put on treatment for rest of the life, for conditions like high blood pressure and diabetes. You may not be able to cure. He will need to continue for on treatment for most of his life. So health is keeping a person healthy. When you provide healthcare, you have to look at the whole community. And in the community, you have maybe broadly 4 categories of individuals. One is those who are healthy. They don't have risk factors. Unke parivar mein nobody had diabetes, nobody has hypertension, no history of these diseases. So these are the people, and large chunk of people fall in this category. The second one is people with risk factors. Family history of hypertension, diabetes, or high cholesterol. These are the risk factors which may put you at risk of getting disease. You may also be living in a crowded area with unsafe water supply, polluted air. We all live in the city, which is one of the most polluted cities in the world. So these are some of the factors which make you more at risk of acquiring some of the diseases. The fourth category is those people who, maybe give you an example, who are diabetic or hypertensive, but nobody has ever tested their blood or for sugar, or never tested their blood pressure, so they don't even know. So we need to pick them up early and put them on treatment. The last of the 4 categories is those who have the disease, known disease, diabetes है, उनको भी हेल्दी लाइफस्टाइल अपना प्रमोट करना. डायबिटिक्स को हेल्दी पर्सन के अपेक्षा ज्यादा जरूरत है क्लीनलीनेस की, एक्सरसाइज करने की, खाने व्हाट ही और शी इट्स, उसकी स्मोकिंग नहीं करने की, अल्कोहल नहीं लेने की, वो उसके लिए जरूर. उसके अलावा जो उसको दवाई दी गई है वो उसको रेगुलरली लेनी है. Many people who are known to be diabetics or hypertensive don't take treatment regularly. वो ट्रीटमेंट रेगुलरली नहीं लेते तो ब्लड प्रेशर कंट्रोल नहीं होता, ब्लड शुगर कंट्रोल नहीं होता. तो व्हेन यू कम टू हेल्थ केयर यू हैव टू लुक एट द होल पॉपुलेशन. उसके लिए जरूरी है सोशल डिटर्मिनेंट्स ऑफ हेल्थ, वाटर सप्लाई, सैनिटेशन, एजुकेशन, इनकम, employment, and all these factors come into play. So when you talk of health for all, I will not say medical care for all. I will say health for all. That means you keep those who are healthy. I often give an example. Have you ever, swapped the floor clean? गीला हो गया, उसको सुखाया कभी, पोछा लगाया? Okay. What we do in medical care is you put on all the taps in the house, and then you are trying to mop the floor dry. वो पानी तो आता ही जा रहा है, आप कितना भी पोछा लगाते जाओ कभी सूखेगा ही नहीं. So you have to close these taps which are causing disease so that you can mop the floor dry and you can keep people healthy. So that's one example I will give you. Difference between health and medical care. वो नल के खुले हुए बीमार लोग आए जा रहे, आप प्रिवेंशन तो कर नहीं रहे, नलके बंद करो, प्रिवेंशन होगा। फिर उसके बाद जो मरीज अस्पताल में उनका इलाज करो, और नलके बंद रखोगे तो कम लोग बीमार होंगे और कम लोगों को अस्पताल में आके मेडिकल केयर की जरूरत होगी। एंड प्रिवेंशन is not only better, it is also less expensive. It will strain the government budget less. It will strain my and your pocket less. That's my take on health for all.
Yes, sir. So, sir, like we will like to know that are there any specific experiences or any idea for action for public task force to make the healthcare more accessible, accountable, affordable, and outcome driven for every individual of India?
Okay, I'll give you a few examples. One is the National Health Policy 2019, in which I said Dr. Rajendra Pratap Gupta made a substantial contribution. You have been having health policies. The first one 1983, second one in 2003, और उससे पहले 1946 में Bohre Committee, Joseph Bohre's committee, and we used to look at it as policy. But none of these policy achieved what was put in writing to be achieved. Time bound manner, Joseph Bohre committee में तो आज तक भी हमने वो नॉर्म नहीं अचीव किए, वो 1946 की है. So where is the accountability? If we do not achieve what is put in the policy, then it is as good as a piece of paper. So when we were working on national health policy, we also looked at accountability and implementation framework. You know, when you put something in the policy, this will be done. Who will do it? By when? So by looking at implementation framework, you will also get to accountability. So along with the policy, we made implementation framework, but that got stuck in the file, never went beyond. So for every document you prepare, there is a need for the government to insist on accountability. To give you an example, in the health policy, we have put that India will spend 2.5% of GDP, government expenditure, 2.5% of government expenditure on healthcare. Who's accountable? Smriti? Kritish, for this, who is accountable? Health Minister? Finance Minister? Cabinet? Prime Minister? Health Ministry always puts up a proposal that we need X amount of money. Invariably, that proposal is cut down. And what they do, they come back to them and say, no, last year you had spent this much, and you are asking for more. Okay, you can spend this and then come and ask for more. You can start with a housewife. If a housewife gets 1,000 rupees to run the household, she will manage in 1,000 rupees. If you give, say, 30,000 crores to Ministry of Health, they will manage in 30,000 crores. Next year, you will say again, oh, 30,000 crore you manage, and why should we give you more money? You know, some of these things need to be looked into, and accountability will go to somebody who refused to give the money to the Ministry of Health for implementing health program. This is one example. When you go down, then it is division of a particular disease in the Ministry of Health, who is accountable. Then you go down to state level for implementation, they are accountable. Unfortunately, when you have accountability, somebody died in surgery in a hospital, the first one who will be terminated is the doctor who operated. But who is responsible for providing infrastructure? Who is responsible to providing the equipment? Who is responsible for providing maintenance of the equipment they have? So, you know, it's very easy. The most peripheral person, you terminate that person when accountability is at a higher level. So that is one thing I feel bad that we have not included accountability. If you include accountability health policy, it will go down to program, it will go down to project, and every level you will have accountability. So that's one aspect I feel in our work in public task forces, we were not able to achieve. Even today, we don't have that. But I can go and on. But this is one thing I wanted to emphasize, and it cuts across all the activities in health sector.
Right. So just a reminder, if you have any questions to the speaker, you may write in the Q&A box.
Smriti, I didn't hear you. Kritish, can you repeat the question?
Sir, actually, that is not the question, just a gentle reminder that if participants have some questions, they can write down into question and answer section.
Oh, okay. I don't have any questions for myself, so not applicable to me. Yes, audience, please do ask your question. Whatever is in your mind, please put it. I may not have all the answers, but I can give you some perspective from my own experience. Thanks, Smriti, for reminding.
Yes, sir. So there is a question from the audience. They ask, sir, could public health officials be important stakeholders?
Public health officers. So I don't know what exactly you mean from public health officers. These are public health qualified people, I presume? Oh, okay. So these are public health qualified people. They should be responsible for all the public health programs. And the guidelines which have gone from the Ministry of Health, they have clinical cadre, all the specialists who provide medical care. They have public health management cadre who manage all the public health program. Then they have public health specialist cadre, which is the, public health management cadre will have people right from ASHA upwards. Yeah. And then public health qualified people, their cadre will have public health specialists who will be in charge of various programs. And the fourth cadre they are saying is academicians, the faculty in medical colleges. So anybody who wants to be a specialist in public health has to have a degree in public health. Otherwise, he or she cannot move to that cadre. So when this is rolled out, to give you example, two states come to my mind, Maharashtra and Tamil Nadu. Tamil Nadu, we used to have public health cadre in British days. It was dismantled. But Tamil Nadu did not dismantle. So when you look at health indicators, management of epidemics, etc., Tamil Nadu comes out to be doing very well. Maharashtra brought that cadre back. And many of the health indicators, Kerala has public health cadre. So many of these states who have public health cadre are doing very well in addressing public health needs. But we need to roll it out across all states and union territories, which is being done now.
Yeah. So, sir, next question is from Kapil Rawat. He says, do we really need more PHC, or having more HWC will be right away?
We should have more PHCs, more health and wellness centers. I fully agree with this proposal. What we are doing is we are opening aims. I think we have 22 aims at the last count, and there may be more and more. There is more and more demand. We are opening medical colleges. But if you want to have more health and wellness centers or sub-centers, you want to have more PHC. In addition to the doctor, you need all the staff. You need nurses, you need nursing supervisors, lady health visitors, you need ANM, you need multi-purpose workers. Unfortunately, multi-purpose health worker male, they are being, as they retire, their positions are not being filled up. You need a strong primary healthcare team so that most of the health problems can be detected at an early stage. They can be prevented, where those who have risk factors can be followed. Those who go to hospitals and come back home, their compliance to treatment can be monitored. It's not that the specialists who prescribe medicine in a medical college will come back home to monitor. It is the grassroots level functionaries who will monitor. So that aspect of primary healthcare needs to be strengthened, and that can be strengthened when you have more primary health centers, you have more health and wellness centers. That is the new term now for the old sub-centers. And you need to have that. If I have somebody visiting my home, Dr. Sanjiv, did you take your medicine? Are you taking your medicine regularly? And how's your blood pressure? Can come and check my blood pressure. No, your blood pressure is high. So you need to go back to the doctor and maybe he will increase the medicine. But when I tell him, when I get up from the bed, I feel giddy, I feel I am going to fall down. He checks my BP and says, oh my God, your BP has gone down. You need to reduce your medicine. That kind of linkage should be required. And what happens now? For every new symptom, every new problem, I have to go maybe 50 kilometers or 100 kilometers from a rural area to get my BP checked and get my medicine dose adjusted. Similarly for diabetes, if my blood sugar is not contained, and now you have, easy to test, home test of blood sugar, you can do it, you can discuss with your primary healthcare worker, and then if required, he or she can refer you to the specialist.
Yeah. Dr. Abhijit asks, do you think our present public health system is grossly working in isolation? There is no coordination and cooperation between different arms of public health systems.
Yes. I won't confine to public health. I will expand it to the whole healthcare system. As we said earlier, more people go to private sector. There is no coordination between private sector and public sector because patients are the same. I live in South Extension in Delhi. AIMS is next door to me. I don't go to AIMS. I go to my family physician for my advice, who's a private doctor. But if required, I can go to the government system. So one is we need coordination and collaboration between public and private. Then it comes to various departments. You have malaria, now they call it vector control, which includes dengue, chikungunya, malaria, filariasis, all put together. A person who is handling this program at district level does not talk to the district tuberculosis officer, for example, doesn't talk to the district non-communicable diseases officer, for example. There is a need. But within health sector, there is a chief medical officer or a person who heads all the health programs, and at his level, all of them come together. Then at state level also, they all come together. So within public system, there is some coordination. It may not be perfect, but there is some. But there are many other players. When I say private hospital, who constructed the primary health center? Did the medical officer and health workers build that? Who gives them medicine? All of them come from private sector. Building construction is contracted to a private contractor. So influence of private sector on healthcare is much more than what we see only as private hospital or private practitioner. We need to bring them together. Medicine, high quality medicine, good quality medicine come from private sector. We used to have some government companies which have gradually died down, and they are procuring medicines from the private. Equipment, government doesn't make equipment, it is made by the private industry. So there's a lot of penetration of private industry even in the public system, and we need coordination with all of them. If the supplies don't come in time, nobody can provide healthcare. Neither public nor private sector can provide healthcare. So we need strengthening of coordination. I think your question is very valid, and it is not one day job. Oh, today I have achieved nirvana. No, it has to continue day in and day out, and every day you have to look at how well we are doing as a group and improve upon वर्किंग टुगेदर. पेशेंट इज द सेम. मैं मलेरिया के लिए जा रहा हूँ, दूसरा ब्लड प्रेशर के लिए जा रहा है, तीसरा किसी और बीमारी के लिए जा रहा है, बट वो ही इज वन इंडिविजुअल. So we need to take care of that individual, that family, that community by coordinated effort among ourselves.
Yes. So, sir, the next question is, how can we make treatment of mental health more affordable and accessible? Because even for the educated middle class individuals, the affordability and accessibility issue still prevails.
Very, very important question. And mental health is one group of diseases which are neglected. Not only by healthcare providers, we have much less psychiatrists in our country than we need. We have much less counselor than we need. but also at our own level. Who is, if I am having, say, anxiety disorder or depression, will I tell in public, oh, I have anxiety disorder or I have depression? We hide. Mental health problems, we hide. Not only we hide, even our family, no, don't worry, we just lost a family member, so you are feeling bad about it. But who will deal with extended period of grief, which is causing me depression, which is causing me procrastination? I am not able to do the work I was doing early. So we need to pick them up early. And it is a continuum. Anxiety disorders, for example, start with worry, start with thinking, in fact. Every one of us thinks. You have thousands of thoughts crossing your mind. And then you keep thinking of one thing. One thought came to my mind. Oh my God, China has COVID and people are dying. So what will happen to me? I will also die. My family members will die. So that anxiety, that thought becomes worry. Worry is normal. Worry is normal. We need to deal with it. When that worry becomes anxiety, it starts affecting my day-to-day life. And then in anxiety, I need to talk to my family, my friends. We have stigma that, oh my God, I am getting depression. I am getting thoughts. I feel like crying when I am sitting alone. These things we don't share. Speak up. WHO slogan, I think about 3 years back on depression was speak up. Talk to your friends. Government services we can look at. But it's not there. Everybody who has worry, anxiety doesn't need to go to a psychiatrist. You have a mechanism to support that person. But yes, you need to also know when to go and where to go. And everybody doesn't need psychiatrist. Maybe before that you need a counselor. Do we have sufficient counselors? We have counselors in at least most of the schools. But how many children go to the counselor? Children have a lot of anxiety, lot of peer pressure. They also need, mental health. We as individuals need to start looking at more openly and understand what is the thinking, what is worry, what is anxiety. This is one example. I will not be able to go into a lot more detail. Who has to do it? The government. Ultimate responsibility for health, including mental health, is with the government. They have to make sure that children are educated in school, in colleges, at workplaces, and anybody from health system who comes in contact with me or you should be aware of this and should guide me properly. So yes, ultimate responsibility there, but we also have to do our homework.
Yes. So Dr. Abhijit is asking, for a truly universal and equitable healthcare delivery, should we depend upon NHS healthcare model?
Yes, I think that is a flaw in our system. We look at one model and then we want to replicate. NHS model of United Kingdom, those who are not aware, is one of the best models. Everybody in the UK, and I remember when my daughter was studying in UK, she was also entitled to NHS. So when somebody fell sick in their hostel, they will ask for a cab, and 2-3 friends will go with the person to the nearest hospital. And when they are looked after, the cashier, there is also a cashier there, not to take money, but to reimburse taxi expenditure. So, we normally say government is providing free. Why don't people come? But you don't look at opportunity cost. And if they are going free, 1 or 2 friends are also interested in accompanying them to the hospital. If the person forgets to tell something, they also contribute to telling the doctor, this is what happened to her yesterday or day before. This is what we see is not normal. For example, anxiety disorders or depression. Others will realize more than what you will realize yourself. So that is a very good system, but it is becoming unaffordable. There is a huge waiting list. You will take months to get. Switzerland has more or less similar system. When I was posted in Geneva, Kritish, I had severe backache. I was traveling, I told you, started with 28 countries and came down to 22 countries when I left. I was practically traveling 2 weeks, 3 weeks, thousands of kilometers, most of the times at the airport or in the hotel. I had severe backache. And I am a doctor. My wife is a doctor. We were calling a hospital that we need orthopedic surgeon. They said, come after 1 week. I am in pain today. I don't, it's not an emergency that I go to emergency. So finally, good for us that one orthopedic surgeon himself picked up the phone. And we explained to him that both of us are doctors. This is what I said, come immediately. So I was able to go and visit that orthopedic surgeon. So there are some weaknesses in the NHS, but I will still say it is one of the best healthcare delivery system. You don't have to spend any money. And NHS is, I would say, well equipped and good services they provide. Quality of care is always looked into, but there are some weaknesses which we will need to address if we want to take up that system in India.
Yeah. So, sir, the last question for this session is, how important do you think it is to develop a culture of accountability and leadership in healthcare, especially in developing countries like India?
Nothing can be done in the right manner if we do not have accountability. Accountability at every level. I'm not looking at accountability only in the government system. Accountability at my level, if I am hypertensive, the doctor has given me prescription. And how often I will go to the doctor? Maybe once in 2-3 months. If my symptoms are okay, my BP is controlled, I will not go there. How often will I go to cardiologist? Maybe once in 5 years, once in 10 years. Maybe when you start treatment, you will go there. Rest of the time, I have to make sure that I take low salt diet. I take my medicine as prescribed. I do regular physical activity and so on. So accountability at the patient level, you call it responsibility or accountability. These are, two sides of the same coin. Then the accountability of the healthcare provider. I go to the doctor, he gives me medicine, but doesn't ask me to monitor blood pressure. I don't bother. My BP shoots up one day, 180, 190 by 110, 120, I get stroke. Because the doctor did not tell me if you have these symptoms, you come back to me. It is my responsibility to be sensitive to those symptoms and take immediate action. And then the doctor has prescribed medicine. If I am entitled to free treatment, do they have medicines? Or he has given me medicine, I go to the chemist if I have to buy it for myself. The chemist says this medicine is not available, I have a substitute. Is that doctor available to me on phone? Sir, this medicine is not available. I am being given a substitute, or I can send him a WhatsApp and he can respond. That is accountability at the care provider level. He is not only available to you when you visit him, he is also available to you when you guide. Then, God forbid, if my BP shoots up and I have stroke, I don't know whom to call. It is the responsibility of the doctor to tell me, if you get these symptoms, call so-and-so. And if you reach the hospital within a couple of hours, you will be, if it is thrombotic, the blood clot has blocked one of your arteries in the brain, that block can be dissolved and you can maybe become perfectly all right after that treatment. So the timeliness of treatment, I have to detect those symptoms, and the system has to. I go to hospital, nobody is looking after me, I'm lying on one stretcher, my relatives are running around, doctor come and see, and those precious hours are lost, and then by the time they put me on treatment, it is too late to bring me back to normal life. Cardiopulmonary resuscitation, all of us know about it. Somebody suddenly stops breathing, young man on treadmill in the gymnasium. Is the gym instructor trained? Are your family members trained? Something happens at home. There are so many videos available. You can look at cardiopulmonary resuscitation and revive that person. And then you can take him to hospital. If the person has stopped breathing, heart has stopped, you take him to hospital. By the time you reach hospital, they will declare you brought in dead. So that accountability is at the whole spectrum, not just at one level. But ultimate responsibility, as I said when we were talking mental health, is with the government to educate the people, to provide resources so that they can all learn cardiopulmonary resuscitation and they can go to hospital in time. And hospital staff has skills, equipment, supplies to manage those emergencies, which could be life-saving.
Yes, thank you for your valuable inputs. Now over to you, Smriti.
So we can't take any more questions as unfortunately we are out of time. Thank you so much, sir, for such an insightful and informative session. And our next step would be that we are going to come out with one-pager document as action points. And thank you for joining in. And you can join Public Task Force for Accountable Healthcare, be part of this campaign. You can visit our website and register there. It's www.parliament.org. Thank you.